Oh, hi. My name is Sandipan Pati. I'm one of the associate professor in neurology. I'm an epilepsy neurologist and I work at UTHealth. So now that you have heard everything about epilepsy surgery and about how seizures and epilepsy progress and medical management, I think it's appropriate that we talk the next between neuromodulation in epilepsy. So I think before we start, we just want to give an overview of this topic. And the way people talk about neuromodulation is a sort of electrical therapies. Just like you have drug therapy, like pharmaceutical therapies, we talk about electrical therapies. And in that context, we talk about when do we consider electrical therapies, whom do we consider electrical therapies, how do we deliver the therapies, and then finally, the treatment efficacy and the side effects. So the first one, when do we consider electrical therapies? Obviously, the first thing after diagnosis of epilepsy, we try anti-seizure medications. And we continue to try one after other anti-seizure medications with the hope that the anti-seizure medicines can control the seizures. However, in many patients, it does not work, it fails, and therefore the next step would be to evaluate for possible brain surgery, with the idea that if we can remove or ablate the seizure focus, then the probability that that person would be seizure-free is high. However, in many patients, we are unable to remove the seizure focus because, for example, we do not know where the seizures are coming from or it's not safe. And in those situations, we talk about brain stimulation or electrical therapies. So whom do we consider electrical therapies? That therefore, really the two main important thing is that patients who have multiple seizure foci or the seizures have a generalized onset or a widespread network, multiple parts of the brain. In those scenarios, we cannot take out one part of the brain or we can take out, but it is not going to make them seizure free. So that's one of the places where we say, okay, maybe electrical therapies would help in this situation. The second is in many patients, unfortunately, the seizure comes from areas which is involved with speech, language, motor function, things that is very critical, that is vital. And if we remove those parts of the brain, it's likely to do more harm than actually help. And in those situations, we decide not to progress with brain surgery and offer patients with electrical therapies. And the last one is a soft call where it's more about debate and we discuss with the patients, and in situations, sometimes the patient prefer neuromodulation or electrical therapies over definitive resective surgery. So these electrical therapies or neuromodulation has a long history. And these are some of the examples that I put together. Jose Delgado was one of the scientists in 1950s, 1960s at Yale, and he was one of those who was developing electrical therapies. Irvin Cooper is one of the neurosurgeons at NYU around 1950s, 1960s. Again, he developed a lot of strategies. And more important is that even before that, you know, how exciting it is that people used to think about electrical therapy. And here is an example of a fish, electrical fish. And in those days, people realized in the very past that by giving electrical therapy, that we can control migraine or seizures, things like that. And here is an example of an old picture where in those days, they were trying to get the electrical fish on top of the head and trying to see if the electrical activity from the fish can be transported or transferred to the human brain. You know, obviously we don't do this type of things today, but it tells us that the motivation of electrical therapy is not new. So the targets for electrical therapy or the neuromodulation has been many areas of the brain. And what I highlight here really is the three parts, blue in your highlight, the anterior thalamus, the vagal nerve, and the direct seizure focus modulation. These are the ones that have undergone rigorous clinical trials have gone through a randomized controlled trial, which we say is one of the best way to identify if something is working or not. And these are the three types of treatment that's FDA approved. So in summary, the three approved electrical therapies that is existing today are one, the vagal nerve stimulation, which is here at the neck, which goes through a wire that is wrapped around the vagus nerve. So that's number one. The second is the responsive neurostimulation. That's an intracranial where the electrodes are implanted inside the brain and they modulate. And then the last one is also intracranial. It's called deep brain stimulation, where electrodes sit deep into the brain and modulate the seizure circuit. So vagal nerve is outside the brain, responsive stimulation and deep brain stimulation are inside the brain. So that's, in summary, is what we have after so many years of research and clinical trial. These are the three treatment that is FDA approved, has undergone through rigorous clinical trial. And the reason I have highlighted these in different color, the vagal nerve stimulation is the minimally invasive, the responsive neurostimulation and the deep brain stimulation is actually are invasive surgeries, but they are also FDA approved. So I'll start with the first one, the vagal nerve stimulation, because that's the one that's been first approved. So in the vagal nerve stimulation, the pulse generator, which is here, you can see the example, it sits in the chest just like a pacemaker. And then there is a wire that goes up and it is wrapped around the neck here, a nerve, which is called the vagal nerve. And the pulses therefore are generated from here, and then it goes up and stimulates this vagal nerve, okay? So in this type of stimulation, there are three things. The first one is a chronic intermittent stimulation, which means throughout the day, 24 hours, it keeps stimulating the left vagus nerve. Then the second is that if a patient feels as if they're going to have a seizure, sometimes patients have a warning of a seizure, then they can swipe the magnet on top of this device and it gives an extra stimulation with the idea that that extra stimulation might be able to terminate the seizure. So that's the second one. And then the third one is in some of the newer device, there is something called auto stim. What it does, as you can see, that it sits on top of the chest. So it can sort of sense the heart rate. And based on the assumption that during the seizures, the heart rate goes up, it detects that and then assumes that the seizure is ongoing and therefore gives an extra stimulation. So in summary, the vagal nerve stimulation, which sits in the chest and the stimulation is in the neck, called a vagus nerve. There are three types of stimulation that's ongoing parallelly. The first one is throughout the day, 365 days, chronic stimulation. It does not stops or starts without the seizure. The second is a specific magnet swipe stimulation, where if a patient feels that they're going to have a seizure, they swipe that and they get an extra stimulation. And then the third is an auto stim, which is based on the heart rate with the assumption that if the heart rate goes up, as you can see in this, then it detects that as if there is an ongoing seizure and gives an extra stimulation. So that's vagal nerve stimulation. How does the vagal nerve stimulation works? It turned out that the vagus nerve from the neck goes up into this part of the brain called brainstem, and from that brainstem goes to the thalamus, the other important structure, and then voila, it goes to the entire brain cortex, the superficial part of the brain. So a wave that is being generated from the vagal nerve by the stimulator goes up and then goes there, and from there goes up to the thalamus and then goes all around the brain. And that's how it works. It over time, it stimulates the brain and decreases the excitability. And that's how we believe that VNS works. And here is one example of a study where they're showing that when the VNS is activated, that is, it's stimulating the neck, the vagal nerve, you see these bright spots. These are the areas of the brain called thalamus. They are much more activated. And because this part of the brain is activated, the signals from this part of the brain goes to the entire superficial of the brain and modulates the brain. So the way we do it is we, after the surgeons have implanted the vagal nerve stimulation, the patient is followed in our outpatient clinic, and we as epileptologists are trained to program the device. And what we do is initial follow-up often is within 2 weeks. And then after that, for the first few months, I like to follow them very closely, say within 2 to 4 weeks. And during that time, I will be basically programming the stimulator. We do not want to blast electrical activity because sometimes patients don't like that and they feel discomfort. And therefore, on every clinic visit, which is approximate around 20 minutes, we are slowly increasing the current so that patients actually can sort of adapt to it and don't get a big side effect. And by slowly building up the stimulation, we eventually sort of reach to a sweet spot. Every patient has a sweet spot of stimulation, and we try to reach that so that they get the sort of the maximum bucks out of it. That is maximum control of seizure and minimal side effect. This is one example. There is a wand that the patient actually holds on, and from that way, this wand helps us to communicate with the vagal nerve programmer, and with that, we can actually modulate and change the parameters. So obviously, the most important question, therefore, is that is VNS safety and how much patients can tolerate? What are the side effects? These are all legitimate questions. And turned out that the side effects are really twofold. The first one are all surgery related, that is at the time of implant. Obviously, these are major surgeries in the sense that the patient needs to be put to sleep under sedation, and therefore there are anesthesia related complications. There are the VNS surgery itself related complications like infection, which can be 3 to 6% of the patient. The other ones are that when the surgeons are trying to wrap the wire around that neck, the vagus nerve, it can injure the nerve and it can then lead to vocal cord paresis and some weakness of the muscles. These are uncommon, but it's not zero. On a bigger clinical studies, they have been shown to about 1% of the patient. Now, I must say that with experienced surgeons, this is actually very less. In my career, spanning 2 hospitals, university major hospitals, I've only seen 1. So moral of the story is it can happen, but it's not common. The other thing that I see, though, is much more common is the stimulation-related changes. These are like voice changes. If somebody has a beautiful voice, it becomes hoarse. They can have a little dry cough every time with the stimulations. But again, with my experience, as the patient gets used to it, the cough invariably goes away. The voice change, though, stays there. But I have never heard somebody, patients in the long run saying that you actually decrease the stimulation because my voice has changed. So in a way, often the patients actually get used to it and the family members get used to it. And there's not a major sort of complaint about that. What is interesting is that these all are reversible in the sense if you decrease the current, the stimulation parameters, we can actually get rid of cough, we can get rid of the voice alteration. The last one is the cardiac side effects, and these are again uncommon, and these are related to rhythm problem, like either the heart rate would be slow or they may have some rhythm problems. But again, these are uncommon, and we can actually test by the time when the surgeons have actually done the implanted the device in the OR, we can actually check this, and we do check this to make sure that there is no effect on the heart rhythm. There is no teratogenicity. What it means that if a pregnant woman has a vagal nerve stimulation, it does not lead to any defect to the baby. Now, the next part therefore comes in that how well VNS works, and like epilepsy, like any other therapy, a rule of 1/3, as I say, in 1/3 of the patient, they actually see a huge benefit, which is often like more than 50% reduction in seizures, which means that if they were having 100 seizures after say 3 to 6 months, they will report that their seizures have decreased to 50. In 1/3 of patients, they would say that the seizure decrease is actually less than 50%. So maybe 20% decrease in seizure count or 30% of seizure count. And in 1/3 of people, they report that there is absolutely no benefit. As a busy clinician, I have seen all the three. I've seen people where the VNS did not work at all. I've seen people where the VNS was giving some benefit, and I've seen patients where the VNS has remarkably controlled the seizures. Complete seizure-free, completely and off medication, I have not seen. Okay. So that's my experience really. And another important experience is that I've seen often after months and months of the VNS, often if they are having the full-blown convulsive seizures, then the patients or the family member says that the seizures are of less intensity, or sometimes in quote unquote, their words would be the seizures have mellowed down, and their recovery could be faster. And the other thing I've heard is that people talking about that if they're having a lot of seizures, then it's spaced out. So there's a lot of gap in between the seizure. So inter-seizure interval is much more longer, and the patients therefore enjoy, or the family member enjoys seizure-free period, which is welcoming, and a lot of patients do appreciate that. So one of the things that has been noted that in some people, the VNS can cause sleep apnea. And what it is that often, if somebody is on VNS, has a VNS, and says, you then notice that they are having during sleep snoring, or they stop breathing for a few seconds and then snore. That's when you start thinking that whether that person is having a sleep apnea and that is induced by VNS. There are two different things. The first is that whether that person has sleep apnea or not, that needs a sleep testing and a consultant with a sleep neurologist to confirm that that is indeed a sleep apnea. And then the next question that then comes is this sleep apnea induced by VNS, or is it's just that person has sleep apnea, because sleep apnea in epilepsy is not uncommon. So that's important, and I think it is important to address this, because if somebody has sleep apnea, their sleep is not good quality, and if their sleep is not good quality, then the seizures often gets worse. And that's one of the reasons that if my patients say that they are snoring or they have sleep issues, sometimes I do sleep studies to confirm whether they have sleep apnea or not. And if it is related to VNS, then fortunately, we can actually reverse it. We just have to change the VNS stimulation parameters. And that could be by decreasing the amount of current, decreasing the stimulation frequency, or one interesting thing which we can do is we can space apart the stimulation. Instead of say every 30 seconds it steams followed by 5 minutes off, we can even make that longer. So that's one sort of treatment there. One of the reasons that we believe that the vagal nerve stimulation can induce sleep apnea is by partial paralysis of the vocal cord. So every time when the vocal cord gets paralyzed, then the airflow gets stuck, and that gives rise to sleep apnea. This obviously can be dangerous, and therefore we try to make sure that this is addressed. Below here is an example that when the VNS is on, as you can see that the airflow is blocked because the vocal cord is being squeezed or paralyzed, so as to say, and it prevents the exchange of the airflow. So that's what's happening. Then when the VNS is off, you can see that it's working well, airflow. Again, when it is on, you can see that the airflow is getting obstructed, and that's not good. And therefore, one way, as I was saying, is to either decrease the stream current or actually space them wide apart. Instead of this narrow, we can from here to the next VNS stream could be here. Now, the data on whether deep brain stimulation and responsive neurostimulation causes any sleep problem or not are limited, partly because these are much newer devices, but vagal nerve has been there for over a decade, and that's why we know that it causes sleep apnea. And then the last one is that, which is always at the back of mind for all the loved family members, whether the vagal nerve stimulation decreases the risk of death. And what the studies have shown that yes, it does decrease the risk of sudden unexpected death in epilepsy, and it decreases by almost 30% or more. And that's this study that shows, and then the study is done over thousands of patients actually. It's a huge study, and the data consistent. It shows that it decreases the sudden unexpected death in epilepsy rate. Okay, so that in nutshell is the vagal nerve stimulation. I want to next move to the other two neuromodulation treatment. The first one is the intracranial neuromodulation, which is the responsive neuromodulation. And then the last I'll talk is the thalamic deep brain stimulation. The indication for responsive neurostimulation is that we must know where the seizure is coming from. And that seizure focus cannot be removed because there is some other important functions like speech or language or motor area, and we cannot operate. So that is one indication. And the second is if there are two seizure foci. In that situation, we think about responsive neurostimulation. But what if there are more than two seizure foci, like multiple? And in those scenarios, we think of thalamic deep brain stimulation. So in summary, the indication of when we try to select the right patient for this type of treatment, they're a bit different. Okay, one, the responsive neurostimulation, and the second, the thalamic, they're different. So here is the responsive neurostimulation. And here the pulse generator, instead of sitting in the chest, it actually sits in the skull, where basically there is a small thin bone is thinned down, and a small metal tray is put, and then on top of that, the device is there. This is the pulse generator, and then the electrodes are actually tunneled inside the brain and precisely placed where the seizure is originating. So in other words, right in the seizure focus, these probes sit into there. And what they're doing is they're constantly reading the brain waves. And the moment they detect a seizure-like activity, immediately it starts giving electrical pulses, and then it stops the seizure. And then the brain returns to normal state. So that's exactly how it works. And here is an example of one of my patients who has hippocampus bilateral, has bilateral temporal lobe epilepsy. What it means that the seizure is coming from the left temporal area, and the seizure is also coming from the right temporal area, and therefore we cannot operate. And in this scenario, we have placed one electrode on the left side, one electrode on the right side, and as you can see that the seizure in this scenario started on the right side. The machine then detects it. This blue color means that the machine detected it as a seizure, and then it gives this stimulation. As you can see, TX means therapy stimulation, 1, 2, 3, 4, 5, 6 pulses of electrical therapy, and then the seizure stops here, as you can see. So over time, again, it's consistent. It shows that the seizure decreases over time, and this is one example where with time, there is a decrease in the seizure frequency. What is the safety and tolerability of RNS? The device, again, there are two types of complications. The first are all related to the surgery itself, and there is always a potential risk of the infection at the time of the surgery, and that could be, again, from surgeon to surgeon, it depends, but around 3 to 3.7%. The second is lead damage. I have seen 2 cases where the lead, that is the electrode, that gets damaged. But again, it's not very common. I have lots of patients, but it's uncommon. In the reported study, it's 2.6%. And then in situations, it might need some revision of the leads, the electrodes. What is important is that the stimulation-related side effects, these are very less. The electrical stimulation of the pulses, patients do not perceive them, and it's well tolerated. So often the patient would not know that they're getting stimulated, unlike in vagal nerve stimulation, when often the patients know because their voice changes. Here, there is no stimulation-related effects, and the risk of to cognitive decline is not reported. In fact, if any, over time, some of the patients reports improve in cognition. And here is one example of a study that looked at over 12 months the decrease in the seizure count. On your y-axis is basically the seizure reduction, and this is the number of years, and n is the number of patients. And you can see that over time, the number of patients who benefit from decrease in seizure increases, and it can go higher up into 60 to 65%. There are many other benefits of this device because it gives a lot of autonomous to the patient because they don't have to do the machine. The device actually detects the seizure and stops the seizures, and the patient doesn't have to do anything. So a lot of time our patients actually report them being very beneficial. They can attend the church, they can go to meet other family members, and if they have the seizures, they don't have to do anything. The machine automatically detects the seizure and tries to stop the seizure. So the second is that over time, just like VNS, I have seen patients where they report that the seizures are getting shorter, the recovery is faster, and the intensity of the seizure also gets mellowed down, gets less. Some patients have seizures during sleep, and again, it stops seizures during sleep. And in few patients, and in some studies, they're suggesting that over time, as the control of the seizure gets better, that memory improves. Okay, and one interesting thing that is an advantage of this device is that because we are having direct recording of the brain waves, we can actually optimize other neurobehavioral comorbidities. For example, a lot of patients with epilepsy over time also develops non-epileptic spells. And in situations when these epilepsy patients also have non-epileptic events, it can be challenging to know whether they are having non-epileptic or they are having epileptic seizures. Once we confirm the diagnosis with EEG, we can then ask the patients every time they're having a spell to swipe the magnet so that we can then see the EEGs that are recorded from the brain, from the RNS device. And here is one example. One of my patients who has both non-epileptic events and epileptic seizures. On your right-hand side, you can see that when the patient swiped the magnet, that was a real seizure. Whereas on the left-hand side, you can see when they swiped the magnet, that was a non-epileptic event. So the advantage is then we can actually know how often the patient is having non-epileptic and true epileptic seizures. And based on that, we can then offer cognitive behavioral therapy or medications for this. So it helps us to optimize the therapy, some sort of more of a personalized medicine. Does responsive neurostimulation decrease sudden and unexpected death in epilepsy? And the answer is yes. Just like VNS, studies have demonstrated that over time, the sedative rate actually goes down in patients with responsive neurostimulation. And then the last one is the thalamic deep brain stimulation. Again, here the pulse generator actually sits in the chest where with the wire that's connected all the way to the head, followed by the stimulator actually goes inside the brain, deep inside the brain, and hence it's called deep brain stimulation. So unlike the vagal nerve stimulation, which sits in the nerve here in the neck, the stimulator for the deep brain stimulation is actually deep inside in the thalamus. And this actually stimulates just like vagal nerve stimulation throughout. So 1 minute off, on, 5-minute off throughout the day. Okay, so this is an open loop, as we say, stimulator. And we target the thalamus, and the reason behind this is the human thalamus, which is deep inside. We have two thalami, so as to say, one on the right-hand side, one on the left-hand side, and they are extensively connected throughout the brain. So front of the brain, side of the brain, back of the brain, these are the memory boxes here, temporal lobe. So it's extensively connected. So the idea is that if we stimulate in this part of the brain, the stimulation waves will go up to the brain, side of the brain, back of the brain, and then overall modulate the cortical excitability and over time decrease the seizures. And just like responsive neurostimulation, we see that immediately after the stimulation device is implanted, the patients feel what I call them as a honeymoon period where the seizures transiently decreases. And this is what we understand is called implant effect because we have placed an electrode inside the brain. It immediately has an effect like disrupting different structures. So they feel a little seizure free, but their seizures return. But with stimulation over time, we can see that their seizure freedom rate increases. So there is a cumulative effect sort of benefit over time. So deep brain stimulation does decreases the seizure, and here is an example of the study that shows that over time the seizures goes down, and that number, as you can see, over 6 months to 2 years, that the seizure decrease or the seizure burden improves over time. Deep brain stimulation also reduces the severity of the seizure, just like vagal nerve stimulation and RNS. And just like responsive neurostimulation and vagal nerve stimulation, it decreases the sudden unexpected death rate in epilepsy. So important part would be therefore that what's the safety and tolerability of deep brain stimulation? Again, the first one is always related to the surgery, which linked with the implantation and with the anesthesia related complication. Now, because these probes are probed deep into the brain, there is a risk of hemorrhage or stroke, but that number varies from surgeon to surgeon. Obviously, experience counts a lot, but it's quoted as 1.2 to 4.9%. Infection, rare, implant site pain with DBS in epilepsy, I have not seen yet, so it's uncommon. Again, with the stimulations are not perceived by patients, just like RNS, and they're temporary. In other words, what I'm trying to say is that if somebody feels some sort of stimulation related side effect, and if we decrease the current or decrease this or change the stimulation parameter, then the patients would not feel that same side effect. And then the stimulation related cognitive outcome. Initially, when they did the clinical trial, they were worried because it did some sort of psychiatric, it worsened some sort of psychiatric symptoms like psychosis, but in the long-term study that was not seen. But it is something that we worry about, that the deep brain stimulation can potentially change somebody's mood or cognition. Some are equipment related, like lead displacement or migration and lead fracture, just like responsive neurostimulation. And again, I repeat that in the longer study frame outcomes, they reported there was no deterioration in cognition or depression. In the initial studies, they were worried, the short term, but in the long term, they were not worried. But so the most important message, it tells us that none of the effects or the side effects are sort of permanent, unlike surgery, because these are reversible, these are neuromodulation, and we change the stim parameters, we might as well change the side effect profile. And this is in summary of all the three treatments, and you can see they are comparable in sense that the seizure reduction rates, they're comparable. So what is really important is that the seizure types and the indication. So that's most, like in some patients are good candidates for vagal nerve stimulation. Some patients are good for deep brain stimulation and some for responsive neurostimulation. So your epilepsy team will decide which may be the best option for you. And that obviously is sort of a discussion between you and your epileptologist. When the patient gets implanted, we manage them in the outpatient. A little bit about that. Initially, actually, for this type of device therapy, we need some follow-up, and that's important to know. If a patient is from long distance, then we have to think about at least the first 6 to 1 year follow-up, because they may need every month or every other month follow-up, but obviously with time that could be spaced apart. At least in our clinic, we have organized. We have one specific day where all the patients can come in, and the engineers would be there, and we can optimize the neurostimulation devices. We have access to EEG in the clinic. And sometimes these patients have mood problems, sleep problem, and in that situation, we actually can refer to a sleep epilepsy neurologist. We are fortunate to have one, and therefore we can refer it. And then the last thing, very important, is that all these pulse generators, they have a battery, and that battery needs to be replaced. And again, for different device, different range, but approx, I would say 3 to 5 years. Okay, so in summary, this is the Epilepsy Texas Comprehensive Program, where we can say that we had a vast number of patients with vagal nerve stimulation. We have over 30 patients with responsive neurostimulation. This was approved recently, and the deep brain stimulation approved recently, and therefore we have over 20 patients, and the number keeps increasing. We have a special epilepsy neuromodulation clinic where we have on-site EEG. We have a consultation for epilepsy sleep specialist, and we have very experienced neurosurgeon, which can then implant safely. And then parallel to all this is very important actually to have a vibrant research in neuromodulation. And some of those are IRB approved and supported by federal government. So it helps to really get cutting edge on these neuromodulation therapies. So in summary, neuromodulation is a safer complementary therapy in intractable epilepsy, and the treatment at present is palliative. The treatment, obviously, of neuromodulation comes after we think about surgical resection, and it's only in situation where the surgery cannot be done or is not safe. And in those situations, we think of neuromodulation therapy. It complements the medication management and is, over time, patients actually benefit with a decrease in seizure burden. With that, thank you very much.